Embryology of Conotruncal anomalies and aortic arch. So what we will see today is more related to embryology and applied effect, but not individual anomalies in detail. So this is the timeline of events during the development of the heart. So as we know, week 2 it starts and week 7 the heart is formed. So initially it starts with the cardiogenic areas being formed, and then the heart tubes, and then the beating starts, and then we have the looping, and then we have the endocardial cushions, and then the interatrial septum, the interventricular septum. And after that, between the 5th week and the 7th week, we have the bulbar ridges and the truncal ridges forming, which forms the conotruncal septum, and after that the aortic arch. So we have the sequence of events from week 2 to week 7. However, most of the conotruncal development happens around week 5 and week 6. So what we will see in this today's class is what's primary heart field and secondary heart field. How does the bulboventricular tube and the bulbous cordis form? Then the development of conotruncus, the truncus arteriosus and the conus arteriosus individually, and then a little about the outflow tract defects. And also then we will go through the aortic arch development and the defects related to aortic system. Initially we are going to go through a little basics because that gives us an idea about the role of secondary heart field in conotruncal anomalies. So now let's see by week 2 what happens. So this is at the end of 2nd week, around 16th day of gestation. We have these heart cells which are present in the epiblast cranial to the primitive streak. And from there they migrate cranially into the splanchnopleuric mesoderm, forming a horseshoe-shaped cluster of cells. And this comes to lie cranial to the neural folds. This is called the primary heart field. Now this is a coronal section. If we do an axial section, this is how we will see the splanchnopleuric mesoderm, where the primitive cardiac cells come to lie. And this is the primary heart field. If we take a sagittal section, then this is what it is going to be, the notochord, and this is where the primary heart field lies cranial to the notochord. The primary heart field is responsible for development of the atrium, the left ventricle, and most of the right ventricle. And these cells of primary heart field are specified on both the sides from lateral to medial to form the respective sided structure. For example, the cells of the right side contribute to the right atrium, the right left ventricle, the right atrium, and the left-sided cells contribute to left-sided atrium. And this is called the laterality pathway. So you can see various things are responsible for that, and these are called the signaling molecules. This happens at the same time where the right and the left-sidedness of the embryo gets decided. So this is related to the primary heart field. The remainder of the heart, which includes the remaining part of the right ventricle and the outflow tract, are derived from the secondary heart field. So what is secondary heart field? Now here you can see in a sagittal section of the embryo during the 3rd week of gestation, this is the heart. This is the neural tube, and there are neural crest cells which migrate in just cranial to the notochord, and this is called the secondary heart field. So it appears in the 3rd week of gestation from the splanchnopleuric mesoderm, and it lies ventral to the posterior pharynx. So this is the pharyngeal arches. This is the secondary heart field. And this secondary heart field contributes to development of the remaining right ventricle and the outflow tracts, and also it plays a very crucial role in lengthening of the outflow tracts. The secondary heart field is primarily regulated by the neural crest cells. Now, similarly, like the primary heart field, you have the laterality pathway for the secondary heart field also. And here, what happens is the right-sided contributes to the left side of the outflow tract. So it's the other way. And the left side itself, so the laterality pathway also plays a role for the secondary heart field, but it is the opposite way. The right side itself determines the left-sided outflow tract, and the left side itself determines the right-sided outflow tract. And this is how we can understand the spiraling nature of the great arteries, and also that the aorta arises from left ventricle and the pulmonary artery from the right ventricle. So this is about the secondary heart field. So coming back to the primordial cardiac cells, what happens to those cardiac cells is you have slowly formation of the cardiogenic tubes, and then a single heart tube is formed by diffusion in the midline ventrally of the myocardial cells and the endothelial cells. And finally, we have 4 bulbous projections in this, which includes the sinus venosus, the atrium, the ventricle, and the bulbous cordis. So this is the primitive cardiac tube, or it's also called the bulboventricular tube. So the bulbous cordis has 2 components, the conus, which is the proximal bulbus, and the truncus, which is the distal bulbus. The terminologies which we are using here are used in different ways based on different types of classification, but this I find it much more easier to understand that the whole thing is called bulbous cordis, which is in connection with the aortic sac and the primitive ventricle. And the proximal part of the bulbus is called the conus, and the distal part is called the truncus. And this bulbous cordis finally gives rise to the right ventricle, the outflow tracts, and a part of aorta and pulmonary artery. Now, as it elongates, the cells are added from the secondary heart field, and this causes the lengthening of the outflow tracts. So here how you can see the bulbous cordis is the one which is in green color, and the blue is the ventricle. So after the looping happens at the end of 3rd week, we have a bulboventricular sulcus which is present between the bulbous cordis and the primitive ventricle. So once the looping is formed, at the same time we have the lengthening of the outflow tract, which gives rise to the formation of right ventricle and outflow tracts. So here if we see in this figure, this is the primitive left atrium, this is the primitive left ventricle, and then we have this structure which is the bulbous cordis. Now as we understood, the bulbous cordis then gets divided into the primitive right ventricle, the conus, cordis, and the truncus arteriosus. So the bulbous cordis is usually narrow except the proximal part which gives rise to the trabeculated right ventricle. The mid portion, which is the conus cordis, gives rise to the outflow tracts of both the ventricles, and the distal part, which is truncus, forms the roots of aorta and pulmonary artery. The part between the proximal bulbous cordis and the primitive left ventricle then forms the interventricular sulcus. So now we are going to go through what is conotruncal, and after that individually how a truncus is formed and how the conus is formed. So what is conotruncal? When we use the word conotruncal, it means that it's the outflow region of the developing heart. So as we can see in this figure, this is the aortic sac, this is the conus arteriosus, and this is the truncus arteriosus. So the conotruncal is a segment which is just present proximal to the aortic sac. This is conotruncal. So conotruncal is the conus plus the truncus. The conus is the segment which is present between the ventricle and the seminal valves, and it gives rise to the subarterial coni. And the truncus is the fibrous segment between the seminal valves and the aortic sac, which gives rise to the great arteries. So the seminal valves are going to come somewhere here. So seminal valve development is a part of conotruncal development. Now here two things we have to understand, that in embryology we use the word truncus, and this is not similar to the common arterial trunk, which is a derivative of aortic sac. And similarly, the word conus, that portion of the outflow tract that is proximal to the ventricles, is, this persists in the definitive heart also, and we know that it is the subpulmonary infundibulum in the right ventricle, whereas the subaortic side, it disappears. This is just because the terminologies used during embryology has some connection with what terms we use postnatally. Now the conotruncal, as we know, this is the structure of the conotruncal. Now initially, we can see in this figure that it lies on the right side of the pericardial cavity, but slowly this conotruncal shifts to the midline. And this is because there are two bulgings which appear on the either side of bulbous cordis, which are the right and the left atrium. So this happens along with the development of the bulboventricular looping, the bulboventricular sulcus, and the interventricular septum. Now one thing we have to understand, that neural crest contributes to a significant extent to the formation of the endocardial cushions. We will see what are endocardial cushions in conus and truncus. It also contributes to development of the seminal valves, and it also controls the cell production and lengthening of outflow region. So at the end of it, we understand that the development of conotruncal is contributed by the endocardium myocardium initially, and then by the neural crest and the secondary heart field. Now we come down to the truncus arteriosus in detail. So we understand what is truncus arteriosus. It's a connection between the aortic sac and the conus arteriosus, and this thing starts by the 5th week of gestation. The truncus arteriosus is the distalmost part of the developing cardiac outflow tract. And truncal endocardial cushions play an important role. In the subsequent slides, we will see how they develop. However, these truncal endocardial cushions cause two things. One is they divide this outflow tract into two orifices, and second, they contribute to the arterial wall leaflets. So here we can see the truncus arteriosus. It's actually a small short segment. Compared to the conus, the truncus is a very small segment. So it contributes to the partition in this area and also to development of the seminal valves. So how it starts initially is the external wall of this truncal myocardium has a rim which is called myocardial cuff, and that appears to cover the root of aortic sac. So there's something which is called a rim or a myocardial cuff, which is the starting of formation of the truncus. Now at the same time, you can see that we have two cushions which appear. Now this is the truncus, and this is the superior end, and this is the inferior end. So you have two cushions which appear. You can see here the two cushions. One is called the dextro-superior and second is called the sinistro-inferior. So these two cushions appear at the aortic sac-truncus junction. So this is the aortic sac-truncus junction, and you have these cushions appear. They appear on the superior and inferior side, but relatively right and left side. So you can see here two cushions appearing on the right and the left side, and then these cushions start growing caudally. The right superior cushion grows caudally but towards the left side, and the left inferior cushion grows caudally but towards the right side. And this is how you have these swellings which twist across each other and then form a future spiral septum. These cushions, as you can see here, over time will fuse with each other also, forming a complete septum. So there are two things. One is that they grow towards each other, and second is that they grow caudally in opposite directions. And this is how we have the truncal septum, which is the spiral septum, which gives rise to a complete separation of the orifice of the truncus arteriosus into two openings, which will finally give rise to the pulmonary artery and the aorta. Now, when the partition of this truncus is almost completed, you have two small tubercles which are also seen on the main truncal swellings. Now, about the intercalated cushions, we will speak a little later. However, here we have to understand a similar thing is happening at the level of semilunar valves. That is the lower part of the truncus and the upper part of the conus. And you similarly see two small tubercles which are dextro-superior and sinistro-inferior. Now, these two tubercles are going to undergo complex differentiation, and they finally give rise to the seminal valves, a part of the cusps. They give rise to the right and the left pulmonary cusps and right and left aortic cusps. So after this, simultaneously we have the intercalated cushions. They are the parietal endocardial cushions which develop on the right and the left side. And these cushions then finally give rise to the non-coronary aortic cusp and the anterior pulmonary cusp. So in short, we have to understand that these four cushions develop at the level of the future seminal valves. These two give rise to the two cusps of the pulmonary valve and aortic valve, and these two give rise to one cusp individually of the aortic valve and the pulmonary valve. And these are formed at the end of the counterclockwise conotruncal rotation. So this is how the seminal valves are formed. So now if we see a transverse section at the level of seminal valves, that is the lower end of the truncus arteriosus, we saw that there are two swellings which appear on the right superior and left inferior aspects, which then slowly fuse with each other. Simultaneously, there is development of small intercalated truncal swellings, and at the end of the counterclockwise rotation, this is how it looks. So this is the pulmonary artery, this is the aorta. The pulmonary valve, these two cusps, that means the posterior cusps and the two anterior cusps of the aortic valve are produced by the main cushions. And then the non-coronary cusp of the aortic valve and the anterior cusp of the pulmonary valve is produced from the small minor truncal swellings. Now, having understood this, we spoke initially about the rim or the myocardial cuff. Now, that which forms on the outer wall of the truncus arteriosus slowly retracts downwards, and this happens along with the caudal push of the aortic sac. That means the whole conotrunculus moves caudally, because of which there is development of the intrapericardial portions of the great arteries and also the sinuses of Valsalva. So you can see here in this figure, after that there is sort of an excavation within the lumen of the truncal area, and it produces a central luminal part of each cushion. Slow excavation gives rise to the arterial wall leaflets, whereas the peripheral part then gets arterialized to form the wall of the supporting sinuses. So at the end of formation of the valves, you also have something happening on the external wall of the truncus and also the internal lumen of the truncus. So this is how we would understand the development of truncus arteriosus. Now coming to the second part, which is the conus cordis. Now here we can see this is a sagittal section, and we can see here this is the ventricle, this is the conus, and this is the truncus. So what we saw was the development of this area along with the semilunar valve development. Now we are going to talk about the conus. Conus is a little larger area and it's a little wider area compared to the truncus. Now when we spoke about the truncal swellings, similar questions also appear in the conus arteriosus, similarly on the right dorsal and the left ventral walls, and then they grow towards each other and unite cranially with the truncal septum. This septum is going to divide the conus into two parts, which is the anterolateral portion, which is the right ventricular outflow tract, and the posteromedial portion, which is the left ventricular outflow tract. So this conus has the conal septum, which postnatally we see as the outlet septum. So this is the conus septum, which separates the right and the left ventricular outflow tracts. So if we see in a sagittal section again, this is the spiral septum and this is the bulbar septum. The spiral and the bulbar septum fuse with each other, and then the bulbar septum fuses with the rest of the interventricular septum, which includes the membranous and the muscular septum. And here we can see this is a part which is produced because of proliferation of the AV cushions, and the bulbar septum finally fuses with the rest of the muscular septum. Now, after understanding the embryology of Conotruncal, what can go wrong in the whole process? So we understood that the outflow tract development happens because of the myocardial cells, the endocardial cells, the secondary heart field, and the neural crest cells. So the defects can happen because of either a direct insult to the secondary heart field or insult to the neural crest cells that disrupt the formation of the conotruncal septum, or insult to the neural crest cells which govern the signals to the secondary heart field. And what all can go wrong? It can cause tetralogy of Fallot, pulmonary stenosis, truncus arteriosus, or transposition of great arteries. Now we understand that neural crest contributes to development of the outflow tract, also that it contributes to development of the craniofacial development, and hence it's not uncommon to see the same child having a facial change and also a cardiac abnormality. This is the basis of understanding situations like 22q11 deletion, etc. We will see a little about the individual heart diseases now. Now before we go there are a few things which are to be clarified. The first is the conal and the truncal septa will always correspond with each other in the process, even though we know that both develop from separate processes. The second thing is the anterior conus is the one which is located higher and has a muscular infundibulum, and the posterior conus will have a fibrous continuity between the remaining seminal valve and the AV valves. So in a normal heart we see that the pulmonary valve is the one here which is superiorly located and has an infundibulum, and the aortic valve is the one which is having a fibrous continuity with the mitral valve and the tricuspid valve. The spiral rotation of the conotruncal septum, it occurs before the leftward shift and the resorption of the bulboventricular spur, which we saw a couple of figures before, where you have the development of the bulboventricular spur initially after the looping, and then over time you have a leftward shift of the conotruncal septum. So the spiral rotation occurs much before the leftward shift and the resorption of bulboventricular spur. And also we have to understand that in abnormal situations, the differential in the resorption of the conus into LV does not generate a difference in the rotation of the septa, both of which are independent. So here we can see the first defect which we are going to see is a situation where you have a conotruncal ridge which fails to form, because of which there is no division of the outflow tract. That means that you do not have a truncal septum, and commonly you do not have a conal septum. So this is what gives rise to a single great vessel, which is the truncus arteriosus, and commonly you have a VSD. It's very rare but possible to have no VSD in a truncus arteriosus. So truncus arteriosus, you have a single arterial trunk with an outlet VSD. What if the conotruncal septum forms partially? If it forms partially, then you can have either just an outlet VSD, or you can have just an aortopulmonary window. So different forms of aortopulmonary window are also because of lack of formation of a conotruncal septum partially. The second is transposition. So let's see how transposition occurs. Normally you have this conotruncal septum rotating spirally up to 180 degrees, because of which you have the pulmonary artery left and anterior and aorta right and posterior. Now if this conotruncal septum does not have a spiral course at all and it's straight, then it is going to give rise to transposition, where you have the aorta right and anterior and pulmonary artery left and posterior. If this rotation happens partially, then it can give rise to a situation in between where you can have side-by-side vessels, and commonly this is in association with double outlet right ventricle. So abnormality with the rotation gives rise to transposition and DORV. Abnormalities with the formation of the conotruncal septum can give rise to truncus, AP window, or an outlet VSD. What happens if there is uneven septation of the conotruncal? Then you will have one outflow which is bigger and the other outflow which is smaller, in situations where you can have pulmonary stenosis or atrasia, aortic stenosis or atrasia. Similarly, at the level of seminal valves, if you have partial fusion of the seminal valves, they will give rise to stenosis of the respective seminal valve. We spoke about uneven septation. When you have uneven septation at the expense of the pulmonary site, because of anterior displacement of the conotruncal septum, then it's going to give rise to the most frequent conotruncal abnormality, which is tetralogy of Fallot. This is sort of a summary. However, it is interesting to understand that in truncus arteriosus, the conal musculature is absent, but it's present in transposition and DORV. The conotruncal and aortopulmonary septations are absent in truncus and they are present in transposition and DORV. The left-sided pulmonary portion of conotrunkus translocates leftward from RV to LV in a correct way in truncus and transposition, but does not happen in DORV. and that conotruncal rotation is not there in truncus because there is no septum, but the conotruncal rotation does not happen in transposition and TORV, and in truncus arteriosus anyway we don't have a septum to rotate. So these are few interesting facts which says how these three things are so different in spite of all being the conotruncal malformation spectrum. Now this is the end of the conotruncal development, and now we will see a little about aortic arch development, which happens around the 4th to 5th week of gestation again. And here this is the coronal section of the embryo at 4th week, and we can see here this is the AV canal opening, which is a single opening. This is the left ventricle, this is the left atrium and the right atrium. This is the primitive right ventricle, the conus cordis, the truncus anteriosus, and cranial to that, the truncus anteriosus is attached to the aortic sac. These are the aortic arches which connect the ventral aorta to the dorsal aorta. So the aortic sac is the one which finally gives rise to the aortic arches. So initially it forms two horns, the right horn and the left horn. Now all the pharyngeal arches, they receive their own arteries, and these arteries are called the aortic arches. The aortic arches arise from the right and the left horns of the aortic sac, and this aortic sac is connected to the distalmost part of the truncus arteriosus. And the aortic sac finally terminate into right and left dorsal aorta. So this is what is the dorsal aorta, this is the ventral aorta, and then you can see 6 arches. Now I draw all 6 together, but we have to understand that they are all not present simultaneously. So no point in gestation you will have all 6 together. From cranial to caudal, you number them as 1, 2, 3, 4, 5, 6 arches. Usually the 5th arch is incompletely formed or it regresses immediately, and hence the 5th arch is usually not considered. So we have 5 arches, 1, 2, 3, 4 and 6. Again, out of which the 3rd, 4th and the 6th are the one which are sizable. The 1st and the 2nd also over time will become atretic. And there are lots of changes which are happening in terms of modification and regression of vessels over time. So here we can see this is the opening of the aortic sac, which is connected to the truncus anteriosus, the right and the left horns, and then the arches which are undergoing lots of changes connected to the dorsal aorta. So here you can see the 1st arch is obliterated even before the 6th arch is formed. So you can see here the 6th arch is so primitive initially by the time the 1st arch disappears. And here you can see that a stage later than this, you have the ascending aorta and the pulmonary trunk which is formed by the time the 1st and the 2nd arches disappear completely. The 1st arch, after it disappears, it forms a part of maxillary artery, and the 2nd arch also completely disappears and it forms the hyoid and the stapedial arteries. So the maxillary, hyoid and stapedial are formed from the 1st and the 2nd arches, and they do not contribute to any significant proximal bifurcation of the aortic arch. Now this is the dorsal aorta and this is the ventral aorta, and we saw that the 5th, the 2nd and the 1st disappears. So then we have this, the 3rd, the 4th and the 6th. So we can see here the ventral aorta is connected to the right and the left horns. The right horn here, if you trace here, you can see that it gives rise to the right brachiocephalic. And the left horn gives rise to the proximal part of the left aortic arch. We can see here, it's connected to the proximal part of the truncus arteriosus, where this is going to be the proximal part of the aorta, and this is going to be the proximal part of the main pulmonary artery. So the right horn gives rise to the brachiocephalic, and the left horn gives rise to the proximal part of the left aortic arch. Coming down to the third arch, the third aortic arch, which is the orange colored. So remember that these third arch vessels give rise to the carotids. So on the right side, you can see that it gives rise to the common carotid artery. Side you can see that gives rise to the common carotid artery and the first part of the proximal part of the internal carotid artery. The external carotid comes out as a sprout from the third arch. So it gives rise to common carotid, proximal part of the internal and the external. And on the left side, it gives rise to the common carotid, the proximal part of the internal and the external. So the third arch contribution is bilaterally symmetrical. The internal carotid artery, the distal part, is formed from the dorsal aorta, which is the yellow colored. Now coming down to the fourth arch vessel on the left side, the fourth arch vessel forms the left aortic arch. That's the part between the carotid and the subclavian. And on the right side, it forms the proximal part of the subclavian artery. And here you can see the distal part is formed by the dorsal aorta. The distal part of the subclavian is formed by the dorsal aorta. So this is related to the fourth arch, where both the sides it contributes to different structures, but predominantly subclavian and the arch. Now coming down to the sixth arch vessel, which is the blue colored. On the right side, you can see here, it gives rise to the proximal part of the right pulmonary artery, and on the distal part on right side, it disappears. On the left side, it gives rise to proximal part of the left pulmonary artery, and the distal part gives rise to the ductus arteriosus, which then disappears. So this is the development of the main vessels coming from the arch. There are few small things which also happen in terms of other changes, which is mostly in terms of disappearance. And you can see here the dorsal aorta, which is present between the third and the fourth arch vessels, it disappears. This segment is called the carotid duct. Also that the right dorsal aorta, which is present between the origin of the seventh intersegmental vessel and the junction with the dorsal aorta on the left side, also disappears. And the third thing which happens is that the carotid and the brachiocephalic vessels, they elongate because the heart is pushed into the thorax, because of which the left subclavian artery, which was very much distally, it shifts its origin proximally, and the origin is very close to the left common carotid. So if you can see in this figure, see, this is where the future left subclavian was, and then it gets pushed proximally and the origin comes to lie next to the left common carotid. So these are the few additional changes which also happen. Now, along with this, we will also see a little about the vitelline arteries, which supply the gut, and the umbilical arteries, which are connected to the placenta. So this is esophageal section of the embryo, where you have, this is the heart, and this is the aorta, and this is the venous system. So this is the sinus venosus, and this is the aorta. These are the aortic arches, and this is the dorsal aorta. Now this dorsal aorta, you can see here, also has a branch out as umbilical artery. So umbilical arteries are initially paired in the sense we have the right and the left branches from the dorsal aorta which goes into the placenta. And during the 4th week, they acquire a connection with the dorsal aorta. And then it loses its earliest origin. So after birth, what happens is you have a proximal part which is continuing as internal iliac artery and the superior vesical arteries, and the distal part gets obliterated to form the medial umbilical ligament. Whereas the vitelline arteries, you have these as paired vessels again which supply blood to the yolk sac. They fuse and form the arteries of the gut. That's the celiac, superior mesenteric and inferior mesenteric. But celiac and superior mesenteric are derived from the vitelline arteries. The inferior mesenteric is derived from the umbilical artery. And these are the 3 main vessels which supply the foregut, midgut and hindgut respectively. So now with this understanding, we will see the arterial system defects. And the most commonest, all of you would agree, is the coarctation of aorta or arch interruption. And this happens because of a problem with the 4th arch. 4th arch, if it gets completely obliterated, it's going to give rise to interruption. And if it partially gets obliterated, it gives rise to coarctation. If the patent ductus arteriosus is there, it is due to lack of obliteration of the distal part of the 6th aortic arch. This is easy to understand. Now coming to the subclavian artery which is abnormal. So, for example, you have an abnormal origin of the right subclavian artery in a left aortic arch. So why does it happen? The artery is formed normally, the right subclavian artery, this artery is formed by the distal portion of the right dorsal aorta and the 7th intersegmental artery. You can see here. So if the way normally the subclavian is formed, that part gets obliterated and this part which normally should get obliterated persists. Then the 7th intersegmental artery along with the right dorsal aorta will give rise to the right subclavian. And in that situation, you will have a left arch with subclavian artery of the right side being the 4th vessel. So this is how it's going to take a turn posterior to trachea and esophagus and go to the right side. So you have the right carotid, the left subclavian and the right subclavian. And the right subclavian goes posterior. Now in this situation, if you have a right-sided PDA, then it's going to form a vascular ring. Now coming down to the most interesting abnormality, which is the double aortic arch. So what happens in double aortic arch is, normally this part has to disappear. Again, the same part between the right 7th intersegmental vessel and the connection with the left dorsal aorta. The right dorsal aorta persists. Then it's going to be 2 arches, the left arch and the right arch. And in that situation, you will have independent 2 origins of 2 vessels from the right arch and 2 vessels from the left arch, and you will not have a brachiocephalic. So you cannot have an innominate artery when you have a double aortic arch. And then you have this right arch which goes posteriorly and the left arch which comes anteriorly between the trachea and the esophagus, and that itself forms a vascular ring. Now this figure, if we can see, what happens here is you have, okay, let's finish this, the right aortic arch. So similarly, how we can have a left aortic arch. The right aortic arch is there when you have the left dorsal aorta and the left 4th arch disappearing and the corresponding right 4th arch and the dorsal aorta persisting. Then you will have a right aortic arch and no left arch. Now what happens if you have obliteration of both the aortic arches on 4th aortic arches on both the sides? Then you will have the persistence of the right dorsal aorta here. And this is what will happen. So you will have a ductal arch, you will have an aortic arch, which is not connected in a normal way. So this is also an abnormality where you can have obliteration of both the arch vessels, and then the ductal arch is giving rise to the right subclavian. Now this figure is for all of you. Can you all guess what is this? Can you all guess what is this? You have the aorta here, you have the pulmonary artery here, this is the left subclavian artery, and this is the right subclavian artery. This is the ductus arteriosus. This is actually a combination of two types of defects. Anybody? So you can see here, it's an innominate aortic arch with aberrant right subclavian. Yes. Along with that, you can see here that you don't have a connection between the aortic arch and the ductal arch. So it's arch interruption. Yes, very good, Akshata. It's arch interruption with an aberrant right subclavian artery as the fourth arch vessel. So this is a situation where both the subclavian arteries are from the ductal arch. Yes, correct. So I think this is the end of our talk. Any questions from anybody?